Welcome to our webinar. My name is Brad Siff. I'm the founder and president of BioWave. I'm very excited to introduce our guest lecturer this week, Dr. Charles Odonkor, who's the assistant professor and co-director of clinical research at Yale University School of Medicine in the Department of Orthopedics and Rehabilitation and Division of Physiatry, Interventional Spine, and Pain Medicine. Dr. Odonkor's lecture is titled, My Neck Hurts, Using BioWave High-Frequency Peripheral Nerve Stimulation for Chronic Neck Pain, Innovation for Chronic Neck Pain. I just want to remind everybody that afterwards we will have a Q&A session. Click on the Q&A button at the bottom of the screen to submit your questions, and that will be a live session at the end.
Well, thank you very much, Brad, for the introduction. I'm very excited to be here to speak about BioWave. It's been a great and wonderful addition to my clinical practice. So I'm happy to share my experience, and hopefully we will all learn something from today's presentation. As Brad stated, I'm an assistant professor at Yale in the Department of Orthopedics and Rehabilitation. I also direct clinical research, and I'm the co-lead for neuromodulation clinical practice at Yale. I also do several national committees and organizations in pain and spine, notably the North American Neuromodulation Society. I'm on the research committee for the Spine Intervention Society. I also sit on a couple of editorial boards that have pertinent for the presentation I'm going to talk about today, and have some publications as well in this arena. So I think I do have a little bit of knowledge in this area. So hopefully I can share with you guys what I've learned over the last few months in my clinical practice using BioWave. So before we start, I just wanted to kind of give an overview about my clinical practice and sort of my philosophy in seeing patients. So I do believe in a functional based approach to care as a pain physician. I also have training in physiatry, which is basically a function-based specialty. I believe in doing the right thing each time for each patient, and then also have a commitment to providing exceptional and compassionate care to my patients. And the way we do that is probably to set small, achievable patient-specific goals with emphasis on overcoming mobility limitations. So, everything I do in my clinical practice, the whole goal is to improve quality of life as well as to get our patients up and moving. So that's really sort of the overarching theme of my clinical practice. So since we are going to talk about chronic neck pain, I just wanted to establish a common denominator in terms of what we mean by neck pain. If you look in the literature, there are several definitions, but the most standardized one basically states neck pain is perceived as pain that arises in a region bounded by the superior nuchal line, really at the base of the occiput, and laterally by margins of the neck, and inferiorly by a imaginary transverse line at the T1 spinous process. And this anatomic region is what is highlighted here in this initial figure here in that red section there. So that's really any pain that bounds in this area is considered as chronic neck pain. Alternatively, some also define chronic neck pain simply by what the patient tells you they feel in this area. So objective of our clinical practice as pain physicians is to really try to determine what is the source of the pain and what is the cause of the pain. Because in order for you to provide the appropriate intervention or treatment, you really need to know the answers to these two questions. The neck is a very interesting structure, and basically it has 18 different facet joints that bounce it, and it connects to the thoracic spine to the T1 vertebra. There are also multiple structures that make up the neck, including the nerves, the joints, the disc. Any of these structures could be a source of pain. In addition, we do have also the muscles as well. Before we go on, I think it's important to look at the epidemiology of chronic pain. As most people know, back pain tends to be the most common chronic pain symptom that most patients present with. But right after that, second highest is chronic neck pain. And in 2016, the United States spent about $135 billion just to try to manage chronic neck pain. Furthermore, in 2012, 26 million Americans missed about, on average, almost close to 12 days of work because of severe chronic neck pain. Outside the United States, this is also a big problem globally. For every 100,000 of the population, there's about close to 3,500 persons who suffer with chronic neck pain. If you look at the distribution globally, it looks like mostly Westernized cultures, in the United States, North America, Canada, and also mostly Europe. There's some sprinklings in Africa and North America as well. And there are different thought processes or different theories as to why this distribution persists. Some think it has to do with occupation, and that most Western-based occupations involve folks sitting 24 hours most of the day, sitting behind a computer, couched over like that. And so that might account for some of that percentages that we see there globally. In addition, there are different categories of chronic neck pain. So primarily, the most common presentation you would see in clinic would be nociceptive pain. It accounts for about 43% of pain presentations. The rest would be neuropathic pain. However, there's also a mixed group that would have both. So that's one way to categorize neck pain. Another way to look at it is axial pain, which is primarily pain that goes across the neck, similar to what goes on in the lower back. And then you have radicular pain that sometimes would have radiation going down the arms. Regardless of how you categorize it, both of these types of pain share a common pathway to the brain and also a common underlying physiology for central sensitization. And basically, this is one way that acute pain becomes a chronic pain process. A little bit about the underlying neurophysiology. So most pain initially, especially if it's nociceptive, starts in the periphery with nociceptors, and then either through myelinated A beta fibers or unmyelinated C fibers get conducted to the dorsal root ganglion, and then eventually goes to the dorsal horn. And then it goes through ascending pathways, typically spinal thalamic tract, and goes all the way up to the brain. And then there are descending pathways as well that help modulate the pain. Now, BioWave, which we are talking about today, takes effect more in the peripheral region. Each of these different steps along the pain pathway presents opportunities for pain modulation. And so most pharmaceuticals or most pain interventions try to target different aspects of this pathway here. A little bit about pain in the brain. So for the most part, as a pain clinician, whenever I see patients who have chronic pain, one of the things that I make sure to emphasize is that pain does modify the brain, and if we do not pay attention to this aspect of pain management, no matter what you do, you are not going to get complete success. Okay, so even as much as this presentation today is about BioWave, I just want to put out a little reminder that it's important to understand that the aspects of pain that go on in the brain, in particular, the cognitive and emotional components of pain. And if you are managing pain, looking at more of the distal, pathways, and you don't take care of the central processes, you're not going to be able to fully manage or successfully manage patients who present with chronic neck pain. This slide just basically highlights also the fact that beyond ascending and descending pathways, centrally, there are three different sort of arms of pain in the brain. So we have a lateral pain system, which essentially represents the sensory discriminatory component of pain. So this is really how you tell between, sharp versus dull versus, cold versus heat kind of thing. So that's sort of the sensory discriminatory aspect of the pathway. And typically this control of this aspect happens through the thalamus. The emotional component of pain, goes back to the ancient brain, which is the amygdala. So that's really the medial aspect of the pathway. There are some neuromodulation systems that, purport to address this aspect of pain. And then the last branch is the really intellectual cognitive aspect of pain, because pain really does grab your attention. And essentially, this is sort of the part of the brain responsible for cognition, executive function, the motor cortex and the motor cortex as well. So the point of what I'm trying to say is that, in order to provide comprehensive pain management, we really need to consider each of these aspects of the pain signaling pathway. Again, today's presentation, primarily is looking at more of the distal aspect, how pain gets conducted up to the dorsal root ganglia. And this is primarily the part of the mechanism of BioWave. So what are the different sources of neck pain, as I alluded to before? One of the things that I've noticed in my clinical practice is that 90 out of 100% of cases that present to me typically have a component of muscle-related pain. However, we don't really have a very good way of diagnosing this. And indirectly, that means that we don't have a very good way of treating it as well. But thankfully, I think that one of the innovations with BioWave is that it tends to help address this aspect of pain. And as you see here, there are so many different muscular structures in the posterior aspect of the neck. Any and each of these by themselves can cause pain, but then also in unison as a unit, what is known as the functional neck unit can present as a big source of pain as well. So I think that, it's very important to understand what the anatomy is. Sometimes in clinic, I will do injections targeting, various aspects of these muscular structures in the neck. Interestingly, also, sometimes even, patients who have neck pain may have pain that radiates down to the scapula and sometimes also to the thoracic region as well, and can also include some of the shoulder structures too. So it's very important to understand the anatomy, when you see these patients in terms of having a very good diagnosis. A very often ignored aspect, but also a very important source of pain is the ligaments. And very few people actually pay attention to this. So I wanted to just highlight that very briefly. So you have your nuchal ligaments, that's really sort of the most posterior ligaments. And then as you go more anterior, you have the ligaments of flavum. And then you also have these sort of interspinous and supraspinous ligaments. And then you do have your posterior longitudinal ligament as well as the anterior longitudinal ligament. Now, any of these ligaments can also be sources of pain. Unfortunately, there's no good way to image any of these structures, and it's hard to see even with the current diagnostic modalities that we have. You cannot pick up injuries to these ligaments on MRI, but if you have a very good ultrasound diagnostician, you might be able to pick up some of these on the ultrasound. And there are times that I'm able to pick up injuries here. Typically, when we have not been able to succeed at trying to find a good diagnosis, and we've done various things, and patient is not getting better, I typically tend to look at, the ligamental structures to see if there are any injuries there. Other potential sources of pain include the nerves. We also have the disc, and then we have the facet joints, and the vertebra itself can also be a source of pain. And so, yeah, it's very important to kind of pay attention to these structures. Typically, when I get imaging, one of the things that I look for is to look at, again, starting from posterior to anterior, look at the ligamentous structures, starting here. So I look at the ligamentous nuclei and see what that looks like, if it's nice and healthy. And I'll proceed anteriorly. I look at the ligamentous flavum, is it thick, is it hypertrophied? And then you look at, posterior and anterior longitudinal ligaments as well. One of the often common structures that I see affected in patients, some of my patients with rheumatoid osteoarthritis, is the cruciform ligament, or people who have calcium pyrophosphate deposit disease, which is pseudo gout. It's a rare condition, but I have seen patients who present with this. So I just wanted to highlight that in case folks have had similar experience or people are interested in knowing about that. So that was the sources of pain. Now, some of the most common disorders of the neck include mechanical sources. So we have cervical neck sprain all the way through osteoarthritis and cervical spondylosis. Then we also have a whole host of rheumatology conditions as well. So typically you see more of these commonly. In some instances, quite rare, but also quite seriously, you might see infectious etiologies as outlined here. And then, in some of my endocrine patients with endocrine pathologies, typically diabetes or Paget's disease, you might see present with neck pain. And then sometimes as well, patients may have tumors, either benign or malignant. And one of the ways that they will present would be pain in the neck. I wanted to make a comment here about some of the terminology that we use. So typically, people, you see a lot of doctors, even myself, you say, oh, patients having cervical strain, and we say, oh, this is like the diagnosis. But, cervical strain is nothing more than just telling you something has gone wrong with the neck, but it doesn't really tell you the exact pathology, okay? Also, soft tissue injury, again, a very nebulous term, tells you something has been injured. Soft tissue is injured, but again, it doesn't really tell you exactly what the underlying problem is. And then we also have whiplash injury, which, describes the possible cause, but itself is a mechanism. Itself is not the source of the pain. Okay, so just wanted to put that out there. So a very brief overview of the history of the current device BioWave that we have. So back in the age of enlightenment, electric word appeared for the first time in the English language several hundreds of years ago, 1642. And we're proceeding from that, we have the invention of the Leyden jar. And then moving forward to time of Benjamin Franklin, we have this. So this was the first invention of what a battery looks like. So getting together a bunch of Leyden jars in this little contraption here. And then the analogy to this, to me, I think about back in the day when we had these huge mainframe computers, and now we have a tiny little cell phone in our pocket. Similarly, we have, evolution of electrical stimulation going through this sort of different iterations. And now we have this innovative device here, which is the BioWave, a little bit different from sort of the TENS unit. And the first time the TENS unit was used in the United States was by Norman Chile, who developed this back in 1974. And 30 plus years down the road, we still use TENS units. BioWave represents a little bit of innovation, a step above what TENS units are. So here I want to pause and kind of review very briefly my protocol that I use for patients who present with chronic neck pain. So I have two different protocols. One is static, one is dynamic. Sometimes I'll use a blend of the two, depending on the type of patient, as well as the presenting etiology of the pain. And I would typically take a patient through these different neck exercises. And one of the points I emphasize to my patients is that, to use a BioWave, you need to have the neck in a tonic stretch position that elicits the most pain. So if it's flexion, if it's extension, whatever it is that really elicits the most of your pain, you would do that. And then prior to treatment, I encourage the patients to use heat modality because it makes the tissues and ligaments a little bit more pliable. And then they'll perform a 30-minute session. So in clinic, sometimes I'll do like a 5-minute teaching session. We'll go through these different motions. So I make sure patient understands exactly what they need to do. And then once they know how to do it, they're going to go home and do this for 30 minutes at a time. You can do once a day or twice a day as patient finds necessary. So that is the static protocol. This is majority of what most of my patients would do. Typically, the older sort of demographic in my clinic would do the static protocol. Now, for the younger patients, a more athletic group, I have the dynamic protocol, and there are two ways that I do this. The most common one would be to have the patient go to their therapy sessions with their BioWave device, and doing either dynamic stretching or eccentric concentric exercises. The patient would use the device together with the therapist in the first 8 minutes, would set the intensity at 60%, and then after that, subsequently would reduce the intensity, maybe let's say 40 to 50%, and then they will use it throughout their therapy session. So that's sort of one ways that patients would use the device. And then the other dynamic protocol, typically I'll use that in my more active patients, athletes and things like that, who have to do training sessions. They'll have a before and after protocol, and they will do that 30 minutes before their training sessions, and then post-training sessions, sort of kind of a recovery form of using the therapy. And then they have the option of using heat versus ice, depending on what the preference is. Typically, ice would be more for post training recovery. So that's sort of two different ways of doing a dynamic protocol. There are various ways to position the BioWave device in the neck. The most common placement that I typically will use in my clinic is the one highlighted here, the first slide picture frame here. But it all really depends, it's contingent on where is the patient's pain. So typically, if a patient has pain more at the base of the neck, below the occiput, and also involving the suboccipital muscle, this would be sort of the placement that I encourage. If the pain tend to be more central, or if it's more like involving radiation down the traps, then I would encourage either this type of placement here in the fifth column there, or the last one. I rarely use this configuration. Typically patients who have TMJ, sometimes they also have some other stuff going on. And so this is not a very common placement for me in terms of the image here. Now, the most important point here is that, as you can see, for the placement of the electrodes, there has to be at least 1 inch spacing. So these electrodes should not be touching each other. So you can see that this is nicely demonstrated throughout here, throughout these images here. So that was just a brief overview. We talked about the various sources and causes of pain. We talked about some of the common neck disorders that, would come through your clinic. We also have talked about the epidemiology of chronic pain. So I wanted to sort of wrap up here by talking about 3 case studies that I've seen in my clinic in the last year or so. The first case is a 46-year-old female, said CRNA, presented to my clinic, and she had 5-year history of chronic neck and shoulder pain. At the time of presentation, she noted that she was having severe stiffness in the neck. VAS scores ranged from 7 to 10 out of 10. And she was having a difficult time at work because every time she tried to, turn at work, pain would get worse. She was also having a hard time driving to and back from work. And for the last 5 years, she had tried various things to the point where now she was feeling quite depressed about the whole situation. She had failed physical therapy. She had failed over-the-counter medications, NSAIDs, muscle relaxants. She had done some chiropractic manipulations, also tried trigger point injections. She was barely sleeping through the night, sleeping about 3 hours at a time, waking up very tired, not feeling very refreshed, taking time off work, because of severe pain. And then also importantly, from a functional standpoint, one of the things that she really enjoyed was playing golf on the weekends. She couldn't do that anymore. So at the time of seeing her, I obtained X-ray, which was normal. Her exam appeared positive for trigger points. She had really, really tight and taut, sternocleidomastoid muscle, as well as trapezius. She did have a cervical positive facet load, but Burkitt's sign was negative. I usually do that test for radiculopathy. So in terms of the treatment plan for her, I started her on a static protocol with the BioWave script for 2 weeks. Because she was also feeling a little bit down and depressed, I typically would use Cymbalta as an adjunct because it has the dual benefit of doing pain as well as mood. And so she came back after a 3-week trial of the BioWave device, and she was quite ecstatic because at this point she was telling me her depression was beginning to fade away. She actually had gone ahead and stopped using the medication. She only did it for a few weeks. Her pain scores had dropped from 10 versus 7 to barely negligible, barely present. Pain was now 2 versus 1. It's a huge drop in the VAS scores. And she was using the device every other day, once a day. I saw this patient about 6 months ago. So now, this is fast forward. She'd been using the device for about 3 months now. Occasionally, she would use it whenever she gets a flare. She's barely on any medications. Importantly, her neck disability index rating score had improved drastically. She initially, when she came in the first visit, her score was 24. And then about 3 months later, her score was now at a 4. So she'd gone from being moderately disabled by the chronic neck pain. Now she barely has any disability, and she would highly recommend this device to other patients. And then also, she's quite happy, 10 out of 10 rating for the device. Case study 2 is slightly different. This is a younger patient, 25-year-old student athlete at Yale, also a graduate student. 2 years ago, had sustained a head collision injury while playing ice hockey, and subsequently had developed chronic headaches as well as chronic neck pain. Importantly, he had a known history of rheumatoid arthritis as well as ankylosing spondylitis, for which he had been seeing a rheumatologist, and also for the headaches was following with neurology. He noted that VAS score was 10 out of 10 at worst. There were no alleviating factors for the pain. The chronic neck pain for the last 2 years had disrupted his schoolwork, social, family life. He had become quite anxious about the pain and he wasn't sleeping. Pain had remained refractory on opioids. He was taking some Percocet, had tried prednisone, a whole slew of medications. Imitrex was being prescribed for the headaches, and then he was on Plaquenil for the rheumatoid as well as ankylosing spondylitis. He had also, at that time of seeing me, had failed acupuncture, done 2 rounds of traction and physical therapy, had also done some Facet and trigger point injections as well as Botox for migraines, but this had not worked. And so, typically when I see patients like this who have tried everything under the sun, prior to having BioWave, the options for treating patients' pain were quite limited. And one of the things that I would really fall back on would be to refer the patient to see pain psychology, not because I think the patient is crazy, but as I alluded to before, there's a cognitive and emotional component of pain that often tends to get ignored, which if we don't pay attention to, we're not going to be very successful. So anyway, I did that. But in addition, I looked at previous workup, X-ray was normal. I looked at MRI, really wasn't that remarkable, just showed some mild spondylolisthesis as well as, some arthritis. And so because this patient was active and it was during the hockey season, I recommended a combination of a static and dynamic protocol for about 4 weeks. So he did a trial of that, and then followed up with me several weeks later, 2 months later. He actually had successfully managed to get rid of the Percocet. He no longer needed the Percocets, and he was noting that pain scores had drawn from a 10 to a 5 at worst, and then at best it went from an 8 to a 2. So not as drastic as the other patient, but also quite significant and clinically noticeable. He was using the BioWave more frequently than the other patient, almost every day and twice a day, consistently using it 2 months before and after games. And significantly happier now, much better quality of life, less anxious about the pain. Similar to the other patient, he had much improvement in his sleep, sleeping now for longer, 5 hours more than he was doing before. His NDI scores also improved markedly from 30 to a 12. Still had a little bit of disability, but was doing much better. And, his diagnosis was, cervical spondylosis. Also, mechanism of injury for him was whiplash. The other complicating factor is that, he did have rheumatoid arthritis, and that often tends to affect more the proximal neck structures. And so this is a little bit of, in addition to doing the BioWave, I think this patient, it was important for him to have modification of his rheumatoid arthritis medication, which is the Plaquenil. So I asked him to go back and also talk to his rheumatologist to see if either his medication had to be augmented or modified. But the BioWave was a very good adjunct to his treatment. And the last case is it's a little bit more difficult case. So it's a 76-year-old lady that I saw was on Coumadin for AFib. About a year and a half ago, fell down this flight of stairs at home, had sustained a hyperextension neck injury, eventually developing central cord. Then had motor deficits, bilateral upper extremity with some paresthesias, had difficulty with ADLs, buttoning the shirt, using cooking utensils at home, with loss of proprioception. Tragically, also had developed neurogenic bladder with severe headaches, some dysphagia and neck pain. So at the time, she had been treated with the rigid cervical collar and did 3 months total of rehabilitation, inpatient and outpatient. Because of the dysphagia, had to see speech therapist, also saw a physical and occupational therapist as well. I'd seen a general physiatrist, a neurosurgeon, but they opted to not proceed with surgery at the time. So at the time when I saw this patient, she still had some residual upper extremity paresthesias, but fortunately for her, the leg weakness had resolved. So central cord tends to improve more distally to proximal, and she presented classically like this. She still had a mixed neck spasms with headaches, and also was having some radiation of pain going up the skull to the periorbital region in the hospital neck distribution. Her VAS scores was 8 to 10 out of 10, and her pain had been refractory to, again, several different treatments, including medications, Imovig. She had also previously tried trigger points and facet blocks. I don't know why somehow, I'm always ending up patients end up with my clinic. They've done everything under the sun. I'm like, why are you seeing me? Because you've already done everything. And so typically we have to kind of think outside the box and figure out what else can we offer this patient. So for her workup, obviously because of central cord, she still had some residual edematous changes in the spinal cord on the MRI. She had severe cervical facet arthropathy as well as severe moderate to severe stenosis at C4, 5, and C5, 6 levels. So, this patient was a little bit complicated in terms of her treatment plan. And so in addition to continuing some of the rehabilitation things that she had learned in the last year or so, I decided to start her on the starter protocol for the BioWave. We tried that initially, and she really hadn't been seeing that much of an improvement. And so to augment the use of the BioWave, one of the things that, sometimes I try in my clinic, again, as I alluded to before, in terms of sources of pain, I suspected that some of her pain, because of the whiplash or hyperextension injury, that she may have some damage to her ligaments as well as some of the tendons. And so we decided to try platelet-rich plasma. It's a more regenerative approach, because this is slightly different from anything that she had tried before. And so together with the BioWave, I did the PRP treatments. Initially, she was quite sore, but using the BioWave, typically, the time to recovery from PRP injections is about 6 months, but she was able to recover in about 8 weeks. And so the BioWave was really a very good complementary therapy to getting this lady better. So when she followed up with me about 3 to 4 months later, obviously diagnosis was central cord syndrome as well as hospital neuralgia. She was getting about, on average, 4 hours of relief, which is not as much compared to the other patients. Our patients were seeing sometimes 8 to 12, sometimes 24 hours of relief from a single 30-minute session. But again, this patient's injury was more extensive. And so, but 4 hours was pretty good. Scores went down from 8 to a 4 at worst. So about a 3 to 4 point, improvement in her VAS scores, which is much, much better compared to medications. In the literature, a 2-point improvement in VAS scores is considered significant. She has been using the device for some time now. She still does have occasional flares, especially with the occipital neck pain. She was still using her medications, but there was much improvement in her quality of life. The frequency of her pain flares were less, and she had a significant improvement in her sleep, 5-hour improvement in her sleep. Again, her NDI scores improved. So she had gone from severe disability to mild disability. And I think for her, improvement was probably a combination of doing the PRP as well as using the BioWave in conjunction. So, as these 3 different cases highlight, there are different ways to utilize this BioWave in your clinical practice. I think it's a good viable option to complement standard treatment for neck pain. You may modify the protocol, whether it's static versus dynamic or a combination of the two based on what your patient's needs are and what your goals of care are. And as I alluded to in the second case, it's very important to address other aspects of pain, especially often ignored emotional cognitive aspect of pain. There's kinesiophobia as well. Patients fear of movement because they're afraid that movement is going to make their pain worse. But as we all know, lack of movement and immobility syndrome itself can further exacerbate your pain and also lead to muscle atrophy, lead to deconditioning, lead to worse outcomes for your patients. And so always make sure that, you kind of remind your patients about that as well. Okay, so at this point, I am going to pause and happy to entertain any questions. Thank you very much for listening to this presentation.
Thank you very much. That was a great presentation. There are a few questions that have come up. One of the first questions is, what do you explain to the patient in terms of frequency of use?
Yeah. So the general advice is basically to use it as often as needed. And so, if you're having pain throughout most of the day, you can literally have a couple sessions throughout the day, obviously scattered throughout the day, depending on how your schedule affords you to use it. Some patients would use it once a day because they find that that's more than enough to actually buy them at least 8 hours of relief for the rest of the day. But generally, yeah, you use it as needed. So basically, the analogy I would give is how you would give a PRN medication. And so let's say you were taking, I don't know, Tylenol, you take a Q8 as needed. So if every 8 hours you have some pain, you would take that, you take one pill, and if that suffices, that's great. And so you can use the BioWave in a similar fashion on an as needed basis. Sometimes, however, some patients, they will modify based on their response. So if they use it, let's say in the morning, and for the rest of the day, they're still feeling quite great, then that's it. You're done for the day. And if the next day you're doing good, you can actually skip the next day. So it really depends on what duration of relief you're getting from a single session. On average, I've seen that in my population, we're getting anywhere from maybe as minimum as perhaps 6 hours to sometimes as long as a 24-hour duration of relief. But yeah, use it as needed, basically.
Yeah, I mean, I would add to that we've seen with patients that there's a cumulative benefit with multiple treatments over time. And if someone's having a bad pain episode day, they can use it many times. And typically we recommend doing a 30-minute treatment and then waiting 30 minutes for the body to kind of come back to a normal state before you do another 30-minute treatment. And you can do, 3, 4 of those, as you say, as needed. And that can really help take the pain down to a significantly lower level. So there's I guess the point I'm trying to make is there's no limit to the number of treatments that a patient can do. It's used as needed.
Yes.
There's another question here. The question is, once the tonic stretch has been identified, heat applied, then BioWave started, should the tonic stretch be held or activated during the treatment?
Yes, so that's a very good question. So usually when you do the tonic stretch to identify the most focal pain point, and you place the device, you start it, you could probably leave it in that posture. Your patients would leave it in for the next 10 minutes or so. But realistically, it's not possible. Let's say that it was lateral neck flexion that was really causing most of our problem. It's really not realistic to have it in that posture for the next 30 minutes. The whole point of doing that tonic stretch is really to kind of tease out the most focal pain point. And so you do not need to have it in that posture throughout that entire 30-minute session. And it's also not practical. And so what I would suggest, or what I would tell my patients, is really try to identify where, the highest pain point is in the tonic stretch, and you position it. And then, you turn the device on. And once you feel that it's actually reaching that particular area, then that's about it. You don't need to keep, being in that particular posture or pose. Throughout the 30-minute session, occasionally you may want to double check to make sure that you're really hitting the exact pain point. But yeah, you don't really need to have it on throughout the entire 30-minute session when you're using it.
Yeah, no, I completely agree with you. One of the pro tips we typically offer is that during the treatment, if you're treating the neck and you move to forward flexion, just as an example, a lot of times when the tissue is taut, it allows the electrical field to be more concentrated around the location where the pain's presenting. So if you feel like if the patient feels like the sensation from the electrical field is encompassing the point of pain after that person's moved into that tonic stretch position, that's a good thing, because you're really focusing the active electrical field right to the location of pain. So we like to encourage the patient to do that. And it absolutely is very difficult to hold that position for 30 minutes, but someone could hold it for a few minutes and then move around a little and then move back to that position and repeat that for a few minutes. And that is, in my experience, is what we find can be really helpful for the patient as well.
Yeah, and then the other follow-up to that is the static protocol. Whereas, let's say this was being used in a physical therapy session, during all these dynamic stretches, you could actually have it, being used as well for different movements, whether it's passive or active with the therapist. And so the point of that tonic stretch was more specifically for the static protocol.
Yeah, absolutely. And I would comment that, so our physical therapy protocol is typically we want the patient in a static position for 5 to 8 minutes to allow the effect of the electrical field to take place. And there's some hyposthesia that forms in the region surrounding and beneath where the electrodes are placed. And at that point, you can take the intensity down by about 5% to take the edge off the sensation that the patient feels. And then the patient can begin whatever the therapist's regimen is, whether it's active or passive range of motion, stretching, exercise. And because the electrical field removes the guarding effect associated with pain, the patient can move more resistance to a greater range of motion with much less pain. So really, BioWave's facilitating motion, and it allows the patient to more comfortably get through those therapy exercises that the therapist wants them to accomplish. I don't see any other questions here. Any other comments you want to make, or?
Yeah, so one of the things that does come up for my patients is a question about this whole concept where some patients feel they've used the device, let's say, for a couple of weeks, and then they get great response, but they put it somewhere, forget about it, and then all of a sudden they have another pain flare, then they go pull it out, and they report that sometimes the subsequent usage, the effect, they feel that it's not as strong in terms of their pain relief as the initial time that they used it, the very first time around. And so I will get a lot of questions during that time, a lot of phone calls. Hey, doc, I've been using the device. I've been using it for a couple of weeks now. And, I was doing great. All of a sudden, I had this acute pain flare. I'm not sure why it's not working anymore. Am I doing something wrong? Is it the settings? What's going on? And so sometimes
I have an immediate thought to that.
So sometimes we would try to, I don't know if you want to, sometimes we'll try to troubleshoot. We talk to them and say, well, is it something with the placement? And if it's not the placement, sometimes is it because it's not charged or not? So we try to talk them through it. And if I find that there's really nothing wrong with the device, sometimes I'll ask them to come to clinic with it, and then in the clinic session, live session, we'll try to implement it and see if it's truly the case that they're feeling it less and less. And there are times that it's the case. And so, the way I would respond to them would be that, similar to how sometimes, your body can develop tolerance with any kind of intervention where you have habituation. I think that there may be a component of that going on with the device sometimes. And so I would tell them that, maybe give it a break and then try it again and see if you get more of a response. And sometimes they actually do get subsequent response. I haven't had that happen a lot, but I've had a few patients who've had, those episodes where they feel like subsequent usage, they need to go to higher and higher intensities to even have that sub-perception threshold where they can feel like they need to go much, much higher in terms of the intensity level. And so I don't know if you've had those reports as well.
So my first thought that comes to mind is the hydrogel on the electrodes dries out over time and with continued use. So if the pads don't feel tacky to the touch, the impedance of them is much higher. And if the impedance is higher, then the patient has to go to a much higher intensity, which is voltage, to overcome that impedance. So if they normally go to 3 bars or 4 bars on the BioWave Go unit, they might have to go to 5 bars or even max out the unit if the pads are very dried out. So the very first thing I would suggest to the patient is to try a new pair of pads, because the hydrogel is fresh, the impedance is much lower. And the other thing that's really important is patients should clean their skin with a damp washcloth first, because the rubbing action of the washcloth on the skin removes dead skin cells. It opens up the pores to accept the hydrogel from the pad. So that cleaning action reduces the impedance. And then when you put the pad on, the treatment will feel stronger at a lower intensity level. So those are the two things. It's really making sure the skin is clean and making sure that the electrodes are tacky. And if they're not, please use a fresh set of electrodes, because you will get a much better treatment result. It will definitely feel stronger at a lower intensity.
Yes, that's excellent. Those are excellent points. The related to that, actually, sometimes patients will call and say, you know what, I feel like the pads are not sticking anymore and I don't want to buy more. So what I did was I went to YouTube. I saw a video where somebody put saline water or something on the pads, and then I used it again and it seemed to work. And I said, okay, well, if that seems to work, then okay, fine. So I don't know if that's an appropriate, sort of workaround.
It is up to a certain limit. You can put 3-4 drops of saline on the surface of an electrode, rub it in with your finger so the whole surface glistens, wait 60 seconds so it absorbs in. That will definitely improve the tackiness, reduce the impedance, and you can get a few more uses out of them. But that works only so many times, and then you really need to move to a new set of pads. So that's a good interim suggestion for someone that's extremely cost conscious.
Yeah. So on average, how many rounds typically you expected to get out of this? Because what I've seen is in my practice with patients will probably use it for about a month or so, and then by that time they've gone through, depending on the frequency of usage. Some patients go through their pads much faster than others. And so I don't know if you've been able to track that.
Well, I find that it really depends on skin type. And if certain patients have more oily skin versus drier skin, even if they clean it, the more oily skin tends to make the pads less tacky quicker. Dry skin, as long as you can get the dead skin cells off the skin and they're not sticking to the hydrogel on the pad when you peel it off, because that will kill an electrode if you didn't clean the dry skin off first. That's where the pads tend to remain tackier longer in my experience. So, for people with oily skin, it might be 5 uses. For people with dry skin, they might get 8 to 10 uses out of a pair of electrodes. And when I say that, that's without needing to put a few drops of saline on them. So that's like I said, everybody's skin is different. So it's a little bit all over the place, but that's, if I had to give you a ballpark number, that's what we say.
Yeah. That's awesome.
All right.
And another question. I don't know, maybe if you want to.
Yeah, we can go for one more.
Anybody in the audience. So a very common question, I get that 90% of the time. Every time I would present and I say, hey, there's this cool device, you should consider using it. is, I've used this device already. What this is a TENS unit. How is this different? I used this device, it didn't work. Why should I use this other one? So that's a very common initial question that I get. And I do have my response I give to them, but I don't know what do you typically, how do you tell folks the differentiator?
So there's the clinical explanation, and then there's the lay person's explanation, and we're presenting to a clinical audience, but if the patient's asking this question, basically TENS, electrical signals from the TENS unit can't pass through the surface of the skin because of the electrical properties of skin. So as you turn up the intensity of a TENS unit, the patient feels a noxious, twitchy sensation at the surface, which may act like a distraction to the pain, but the electrical signals are not passing through the skin down to where the pain nerves are that are conducting the pain signals up to the brain. BioWave uses high frequency signals that can pass through skin into deep tissue. They get right to the pain nerve. The pain nerve creates a new set of signals that form an electrical field around it that block the pain signal locally, right at the nerve, before it can travel up to the brain. So the analogy is BioWave works similar to a chemical anesthetic like lidocaine or Novocaine, except BioWave is blocking the pain signal electrically instead of chemically. And that's kind of the explanation I would give to a patient.
Excellent. So yeah, I give a very sort of more succinct version of that, but yeah, it's basically the same idea, which is that I always like to give analogies, and I tell them as we move forward, technology evolves, and so if you want to call it a TENS unit, sure, but it's like having a cell phone from 1980 versus a cell phone from 2022. Technology is very different. Quality is different. Penetration is different. And I just keep it really simple. And patients, okay, fine. If you think the technology is better, I'm happy to try it. And then we just leave it at that. But yeah,
it's like comparing a Ferrari to a Hyundai.
Yeah, basically, yeah, right. And then for the more savvy ones who really want to get at the science of it, then we go into the science and on all of that about impedance and dual frequencies combining to single frequencies and all of that. So yeah, so I kind of tailored my response to who was asking.
To your audience.
Yes, exactly. But I like your answer too.
All right.
Awesome.
Well, thank you so much for your time. It was a pleasure having you lecture for us. And this lecture will be on our website later this week, both the lecture and a recording of the Q&A session. Please be on the lookout next month. We will have a new webinar. Thank you so much for your time, everybody.